so we got a first one here. Anybody want to take this one on?
Hi, Dr. Cockerell. This is Natalie. I can take this one.
Great.
Okay, so looks like we have a punch. Looks to be on a hair-bearing area, so not the palms or soles, not mucosal. Could be like an arm or a leg, possibly. It doesn't look like the dermis is super deep. And then looks like a benign lesion, likely a rash. I'd put this,
Big inflammatory process.
yes, inflammatory process, yes, sir. Um, Inflammatory process, I'd put it in like the spongiotic eczematous bucket.
Okay,
Um,
good. There's spongiosis in here for sure.
yep.
And then a little bit of inflammatory infiltrating the dermis. What kind of cells did you notice these were when you looked at it?
So it looks like it's like a lymphocytic infiltrate, kind of perifollicular lymphocytic infiltrate. And then there are also these Langerhans cells and the little like micro abscesses up near the epidermis.
Okay, good. Any other cells in there besides lymphocytes that you noticed?
So we've talked about lymphocytes, the histiocytes, oh, Langerhans cells, and then
This image, but some of these, like they might have a little reddish cytoplasm.
oh, maybe like little eosinophils,
Yeah, there's some EOs in here too. Good.
eos, and then we also see some edema, some like spongiosis in the stratum spinosum, some edema in the papillary dermis area,
Good.
also in the reticular dermis. And
It's
then,
hard to appreciate reticular dermis edema, unfortunately. It's just there's
okay,
so much reticular dermis there, it can get pretty swollen and you don't really see it. But you definitely can see papillary dermal edema. And I agree
yes.
with you that it is here. Absolutely.
Yes, sir. So with the edema, the spongiosis, also it's like lymphocytic and eosinophilic dermal infiltrate, and these pseudoproteor microabscesses, it looks like it just could be like a very upset sponge derm,
When you say upset, what do you mean?
very inflammatory spongiotic dermatitis.
It's like an acute spongiotic
Mhm.
dermatitis. Like,
Yes.
and so what diseases would you kind of throw in there that give you that pattern most commonly?
So things that I would think of would be like atopic dermatitis, contact derm, irritant or allergic, dyshydrotic eczema, maybe like an acute dermatitis. I think things that would be less likely to be acute, but still somewhat maybe in the same bucket would be like stasis derm or subderm, um, tinea.
Yeah, and so you've got all the different things in there that can cause spongiosis. Now,
Hmm.
so that's a good general list, but if you really want to kind of hone it down,
Hmm.
we should ask ourselves how many of those diseases actually give you spongiotic microvesicles, where you actually
Not
get blisters.
many,
Yeah, not too terribly many.
right?
So atopic dermatitis, does that ever give you vesicles that you can see clinically?
Not typically, more
Yeah.
like
Yeah. I've never seen
dyshydrotic.
a case of bullous atopic dermatitis. I mean, they get the widespread erythematous oozing and weeping and secondary staph and
Mhm.
epidermalization, but really you don't get actual vesicles. So if
Right.
you saw acute vesiculation,
Hmm.
that probably limit the differential somewhat. So
Yes.
and you said seborrheic dermatitis. You can get spongiosis there, but have you ever seen sebderm with papillary dermal edema and actual
No.
spongiosis? No, you wouldn't. But you are right. You do see spongiosis in there.
Hmm.
Uh, you can see dyshydrotic dermatitis with that. Pompholyx, for example, acute allergic contact dermatitis. Which acute allergic contact dermatitis classically gives you this degree of
Like poison
marked?
ivy?
Yeah, Roost dermatitis. That'd be the one of the certainly we think about there. Um, you said tinea.
Well,
Can that give you this pattern?
not as classically. I think it was more something to keep lower on the differential, but
Well, I want to invite you to increase the likelihood of that a little bit.
okay.
Look here. Do you see some changes there that I'm pointing out that I don't know if you saw that when you looked at the slide. You know what
Oh,
those little things are that I'm pointing out to you here?
are they little hyphae?
They're little hyphae.
Oh,
Yes,
wow.
yes. And this is kind of where they like to live. This is what we call the sandwich sign, which is the interface between the basket weave cornified layer and the parakeratotic abnormal cornified material induced by all the inflammation. And that's where these organisms live. And you can see with H&E. Now, the board's not going to give you this to do that with H&E alone. They're going to give you a
Mhm.
PAS. But you can see bullous dermatophytosis.
Okay.
A lot of times the diagnosis gets missed. I remember seeing a patient one time that came in from a hospital with an IV in their arm. They'd been admitted to the ER. You know, they thought they had a horrible widespread vesicular blistering TN-like dermatitis, and they sent the patient by ambulance to the dermatology clinic, and they
Oh,
had
wow.
bullous dermatophytosis. It
Wow.
was not anything serious, but they had blisters. And so obviously, whenever, you know, dermatologists or even non-dermatologists especially see blisters, they get freaked out. They think the patient's going to die of a widespread blistering disease. So yeah, you can get bullous dermatophytosis. Which of the dermatophytes tend to give you bullous tinea?
Hmm. Maybe like rubrum?
Well, you know,
Tinea.
they can, but the greater the difference from humans the fungus is, the more inflammatory the reaction. So,
Okay.
you know, for example, T. tonsurans, you know, you see little kids come in with little black dot tinea and whatnot. They have almost no inflammation and their hair is just kind of falling out. You can't get carry-ons, you can't get prominent inflammation from that. But the more anthropophilic, the more the organism is sort of adapted to dealing with people, and it doesn't cause as much inflammation, and so it lives longer in the person. But if you put something like a T. violaceum, you know, from a cow onto a person, they get really super inflamed because the body says, "Hey, you know, this isn't a human organism here. This doesn't belong," and then they basically go in and can wipe it out. It really creates a prominent inflammatory infiltrate to it. So the more zoophilic and geophilic the organisms, like M. canis, for example, and those kind of organisms, the greater the inflammation. So you can, you know, I'm not sure what the organism was here that caused this, but you would think it's more likely to be something that is going to cause more inflammation rather than less when it gives you this degree of inflammation. And one last thing, you did point out quite rightly the fact that this has papillary dermal edema. So there's two ways that this person got a blister from their tinea infection. Here's one way, the actual microvesicles. So you can imagine that when your epidermis gets this much spongiosis, it's going to look like a little blister, probably a vesicle. When you actually get a bulla, that's often more commonly due to subepidermal vesiculation. And what are some ways of getting subepidermal blistering other than immunobullous mechanisms? So we all know like bullous pemphigoid and, you know, pemphigoid gestationis and DH and all that kind of stuff, where you get the immunoreactives here and inflammation comes in and causes a blister. So what are some other ways of getting subepidermal blistering without immunobullous mechanisms at work?
Maybe by force, like with traction causing
Well,
splitting.
like you
Uh,
can't get like a prominent edema, like we're looking at here. That's one way. So if you get a lot of blistering conditions that, you know, we think of blisters, we automatically think of things like, oh gosh, pemphigoid, pemphigus, that kind of thing, blistering disease of the skin. But you get blisters in other ways. You know, you get spongiotic blisters. You can
mhm.
get the papillary dermis, like here, they can be blisters. Bullous sweets, for example, or
Mhm.
this new term they call bullous dermatosis of the hands, which is basically sweets, bullous sweets on the hands. But there are a couple other ways you can get blisters that
Like,
aren't due to immunobullous disease that are subepidermal in nature. Just a couple of others.
maybe like a sunburn causing a blister.
Well, that actually is more intraepidermal. So we're talking about subepidermal, but not immunobullous subepidermal. So we've already
Okay.
said epidermal edema. There's just a couple of three others. I just want to sort of
Like
think about it.
IgA, LABD.
Well, that's also a subepidermal blistering disease due to deposition of immunoreactants. So we're
Okay.
talking other ways of getting subepidermal blisters.
Like infection, maybe?
Okay, what kind of an infection?
Um, an infectious, like maybe infection around the hair follicle, leading to infection around the dermis.
Well, what if you got an infection that caused thrombosis of blood vessels, and then you got epidermal necrosis, and then the epidermis floated off because it's dead? So
Okay.
that's one thing. You can
Maybe
lose,
like a coma blister.
yeah, like a coma blister, or so-called fraction. If somebody lies outside in the cold and maybe they got drank too much or something, that can definitely do it. Or they can get like a secondary infarct, like maybe they get something like DIC, and they clot off all their blood vessels. They get epidermis dies and floats off. That's another way of getting it. You can just get loss of normal adhesion. So you mentioned stasis dermatitis. We see some patients with severe stasis. They get all these blood vessels. They lose the epidermal reedy. They just lose their normal contiguity with the underlying dermis. They can get a secondary blister there that occurs. They can actually get bullous stasis dermatitis in that situation. Scars. To get a scar, they lose the normal adhesion between the epidermis and the dermis. They get a blister there. The mechanobullous diseases, like recessive dystrophic epidermolysis bullosa, that's a blister that occurs down here, right beneath the epidermis and in the level of the dermis. So there's lots of ways you can get blistering. The bullous amyloid, so you get all nodular amyloidosis, it gets blisters, you get cracks in that amyloid, you get a blister. So there are a lot of other ways to get blisters than immunobullous blisters. That's kind of the point. And there's subepidermal blisters. So here it's due to the papillodermal edema that caused it. This probably also contributed, but this may be why it probably looked bullous to the clinician. Okay, good. It's a good differential. A good way to kind of think about that. Okay, who wants to give this one a go?
Good morning. I can do this one.
Good.
So here we have an excision. It looks like a neoplastic lesion at this power. I'm not sure if it's benign or malignant. It seems well demarcated,
Yeah,
but
okay, so
asymmetrical.
you're not sure at this power. Good.
Mhm.
But if you're going to apply the criteria for benign or malignant at low power, what are you going to bet on?
Hmm.
So what are
Um,
you You're looking for breadth, symmetry, and circumscription as the three cardinal features. And what do you see here?
it looks well circumscribed.
Yeah,
The
this is kind
breast
of the end of it right here. I agree with you. It's fairly small, isn't it?
is a small lesion, but there's that vertical component that is extending down, and that gives it an
Does that cause heartburn for you or no?
and maybe.
Well, we'll give you a Nexium or something for that, so you don't have to have heartburn from it. Vertical orientation, interesting enough, tends to be benign. So when something is vertically oriented up and down, that tends to favor benign. So when you see it at low magnification, it's relatively small, seems to be fairly symmetrical. We can kind of draw a pretty good circle around this whole thing, so we know where it stops and starts. And then it seems to be oriented in a vertical fashion rather than in a horizontal fashion. So when things are kind of broad and they're not as well circumscribed, that tends to see more commonly with malignancy than benign. So if you see low magnification, well, this thing's really kind of going up and down like a little wedge, that ought to favor benign. And we may go to higher magnification, change our mind. But at least at this point, we favor benign.
All
What kind
right.
of differentiation do you think it is?
I think it's melanocytic.
Good.
There's like melanocytes forming nests.
So we have two main diagnoses that we have to deal with, right?
There's deep penetrating nevus,
Well, that's
or
getting into the weeds. But at low power, we say, is it melanoma or not melanoma? Well, since you've already decided it's more likely benign, so it's going to be a nevus of some sort. And then we'll jump into the weeds. And so what's kind of the pattern of this? You did notice this deep vertical orientation, which is important to see. We'll talk about that in a minute. But what about the other overall pattern of this? Forget this part for a moment. Let's just look at this pattern here.
There's melanocytes nesting. They look epithelioids and spindled. There's also melanocytes nesting in the junction. And
Good. Good. There's a junctional component and there's also a dermal component. Notice how it's relatively diffuse in this one area here. And it also goes around adnexal structures and blood vessels. Do you know what kind of nevus, other than a deep penetrating nevus, which is a subtype of this nevus, by the way, what kind of nevus tends to give you that pattern overall?
a compound nevus.
Well, it's a compound nevus, but what pattern gives you, nevus gives you this pattern of fairly diffuse involvement of the upper reticular dermis and around blood vessels and adnexal structures.
A congenital nevus.
Good, good. Congenital nevus tends to do that. Very good. Now, you mentioned deep penetrating nevus. That's a subtype of congenital nevus. If you biopsy 1,000 congenital nevi, you're going to see this component in a percentage of them. In a percentage. Why do they call this deep penetrating nevus?
There's a deep penetrating component to it.
Basically correct. It's a deeper component. And so they said, wow, you know, it's got this little clone that kind of goes down more deeply and the cells are large. And, you know, they've got this, if you take these cells and transplant them into a dysplastic nevus at the junction, they look the same, which is kind of interesting. So it's almost like the cells of a dysplastic nevus have formed these nodular aggregations and they just kind of extend more deeply. And they're almost always associated with the overlying pattern of a congenital nevus. So it's probably just kind of a variant of a congenital nevus or a blue nevus. Blue nevi also are congenital the vast majority of the time too. You know, you don't usually get blue nevi developing in people in their 70s. You know, they usually are seen in childhood and they may get a little darker when they get older. But that's also basically kind of a variant of a congenital nevus. So this is just one type. And I'm glad you recognize it. Glad you recognize it's benign. I just realized it's kind of a variant of a congenital nevus in a way. You're probably not going to encounter this on the board examination. It's a little bit esoteric, but this is basically a variant of a nevus, not melanoma. So that's important that you recognize that. Now, some people, you may read in the literature about this whole new terminology people have introduced over the last few years of melanocytoma. I don't really want you guys to worry much about that either. It's kind of confusing. It's more of a genetic, hypothetical story, if you will, that says, well, you know, we see these lesions and we do genetic studies and they have one mutation and we think if they stick around long enough and so the second hit comes along, well, they're going to turn into melanoma. But a lot of them never do turn into melanoma, and the ones that get excised, we're never going to know what happens to them. So it's sort of speculative, but that's kind of what's going on in literature. They're calling all of these lesions, and this is one of them, gets lumped into this melanocytoma category because it carries a certain type of genetic mutation in them. And you probably will get on the board something about some of these new fusion genetic nevi, like Spitz's nevi that have ALK fusions in them and things like that. Just understand that there have been a lot of people doing research on these melanocytic lesions. They've done genetic research on them. They look at the morphology, they do genetics, say, you know, this one harbors an interesting fusion that's associated with it. That fusion doesn't mean it's benign or malignant. Fusion doesn't mean it's going to turn malignant. We see a lot of these fusions, and they see some of the fusions in melanomas. We see some of the fusions in benign nevi. So it doesn't mean that the lesion is malignant. If you order that test or somebody orders it, it's sort of just, they're doing just kind of more for interest. It's not something that really has any prognostic value to it necessarily. Okay. This is a good example of this here.
Good morning, Dr. Cockerell. This is Hannah. I can take this one.
Okay, good.
Okay, this looks like a little shave. And then it doesn't seem to have much of a stratum corneum.
Good.
So it kind of makes me think of a mucosal surface.
Is there anything else that makes you think of a mucosal surface other than that fact?
Also, it doesn't really have much of a granular layer.
Good. Has no cornified layer to speak of, maybe a little bit here, and no granular. Is there anything else that helps you?
And then kind of in the epithelium, I think you can see some like glycogen there.
Good. Yes, there's glycogen here. And mucous membranes often have some glycogen in them. I'm not sure why. Maybe it likes sugar more than other parts of your body. I don't know, but it's very common to see clear pallor in epithelium of the mucosal surfaces. So that's good. So that's very good. So that's an important clue. So there's that limits the number of diagnoses quite a bit. There's some diseases that occur pretty much only on the mucous membranes. There's some that occur more commonly on the mucous membranes. There's some that occur never on the mucous membranes.
And then it looks more inflammatory to me. My eyes are drawn to like mostly the papillary dermis, a little bit of the reticular dermis has this kind of brown or black pigment that I can see stand out.
Okay, good.
And then going in a little bit closer, I was trying to see if there are any like underlying melanocytes or histiocytes that the pigment was surrounding, but I didn't really appreciate any cells like that. Mostly just seemed to be like intermixed with the collagen.
Okay, good. So you're looking at a dark material, color. So you have to have a differential diagnosis of what that material is. What do you think the dermatologist's #1 differential diagnosis was when they took this biopsy in the clinic?
Like a mucosal like melanoma.
Yeah, exactly. They had one differential, rule out melanoma. So now you've got this, you see something dark. So you've got to decide, could this be melanoma, right? Because that's what the clinician puts down on the rec slip, rule out melanoma. So you got to rule it out. So how are you going to do that?
In this case, it looks more like exogenous. It doesn't look like there's any like melanocytic nesting,
Okay, that's
or
good.
atypia. So it's a lot more reassuring looking at it here.
Now, if this were on a mucosal surface and it were melanoma, do you have to see nesting in early melanoma on a mucous membrane surface?
Not necessarily.
Yeah, the way I asked the question, you clearly know the answer is no.
Yeah.
So I guess the follow-up question is, what do you see in real early mucosal or acral melanoma, like the nail unit, for example? Since you don't see nesting early, what do you see? That's the clue that you're dealing with melanoma in an early stage in that area. That's a harder question. You may not know, which is okay too.
Yeah, I'm not so sure what I'd be looking for.
You see proliferation of melanocytes. It's subtle and difficult to determine, but they have broad, large dendrites that extend high through the epithelium. So
Okay.
if we look for those things, we're looking at an acral, melanoma, say on a nail unit. We're looking at large, sort of thicker dendrites that extend not just barely above the DE junction, but they go all the way kind of up to the upper surface of the DE junction. That's a sign of asymmetry, and it's a red flag when you see that. And it
Okay.
can be really subtle. You're going to be biopsying some nail unit possible melanomas over the course of your career. When you do those, you want to make sure that whoever's looking at it knows what they're doing, because those can be quite subtle. They look a lot worse clinically than they do histologically a lot of times. So we don't see nesting, but we'd want to look to see if we see dendrites, and we don't see those. But we do see some kind of color change here. There's some pigment at the base of the epithelium here also. There's maybe even some in the epithelium up here too. So is this melanin or is it not melanin?
I don't think it's melanin.
Okay, good. It's not. And why do you think it's not? There's a couple of things that can help you here. Unfortunately, it's a little harder to see with this digital image, but if we had an actual glass slide, I could show you even better.
I think kind of how it's like dispersed within the fibers of the collagen seemed.
Okay, that's a very, very important point that you said right there. Note, you see this right here? You see these little structures here? Those actually aren't collagen bundles. Those are elastic fibers.
Okay.
You see how they're dark and brown? What's happening here is that this is almost like a special stain. It's an in vivo special stain that's highlighting these elastic fibers. And if you want to do a special stain for elastin, somebody does a skin biopsy and they say rule out elastofibroma, and you're going to order a special stain for elastic fibers. What's the chemical in the elastic tissue stain that stains the elastic fibers?
I know you can use like a Van Giesen stain for elastic fibers, or
Okay,
but like
you can use a Verhoeven Van Giesen stain.
Mm.
And what is the stain in the Van Giesen stain that stains the elastin? What is
is
that
it
material?
silver?
Yes, good.
Okay.
It's a silver stain. And here you got these elastic fibers are stained brown. And why brownish black? And if we had a high magnification view, we see the little tiny particles, black dots, teensy tiny particles that are staining these elastic fibers. So what's the diagnosis?
So I think it's an amalgam tattoo.
Yeah, it's an amalgam tattoo. And what is an amalgam tattoo?
So it's like, from my understanding, when dentists would like do procedures, they
Yeah,
would
wood
like
is the key there, by the way.
in the
I
past.
got those kind of feelings when I was a kid. You don't get those today. They don't use this stuff anymore. So this patient's
Yeah.
probably an older patient. But yes, and it's called silver amalgam. Now, we can go back to the days of, you know, chemistry and alchemy and all that stuff when they were trying to turn different metals into gold. And so they take silver and mercury and all these things, and they put them together and it makes an amalgamated compound. And the silver amalgam that they used to put in these silver fillings, you know, it had mercury in there too, would actually, when they would slip or something, you get a little piece of it in your gum, then it looks black, and you do biopsy and it looks like this. And that stuff actually, the silver stains the elastic fiber. So basically, this is like an in vivo Verhoeven Van Giesen stain, is what you're looking at here.
Mhm.
Now, we do still see these today. What's the most common setting where we see this finding today? Not from the dentists,
Mhm.
not even the mucosal surfaces.
Would you see this in like sites of piercings?
Yes, yes, the silver that's in those piercings that people get, sometimes you'll get this related to that too. And what's the last setting where we can get staining of the elastic fibers more diffusely?
Argyria.
Yeah, in Algeria, somebody's using the silver containing nose drops or eye drops, or they're drinking it or whatever. So yeah, those are the three settings where we see mercury amalgam. So there are other metals. We don't get into all the different diagnoses of the metallic things that can stain the skin, but this is an example of a amalgam tattoo that happened. I think this one, I don't think was a piercing. I think this was actually related to a dental process. All right, very good, excellent.
Thank you.
Good morning, Dr. Cockerell. I can take this one.
Okay, great.
So this looks like an excision. I see lots of sebaceous glands, so possibly somewhere on the head and neck.
Good.
As far as inflammatory versus neoplastic, I don't see many inflammatory cells, so I would probably favor neoplastic for this one. It does look pretty
That's
well.
the main criteria you use, though, for whether something's neoplastic or not, just whether there's inflammatory cells or not? Because, I mean, you get some neoplasm with no inflammation.
Well, I guess it also just looks pretty well circumscribed.
But there's something here that doesn't normally belong here, right?
All these sebaceous glands.
Yeah, yeah. So it looks like it's a neoplasm or maybe a hamartoma. And you said at low magnification, it's sebaceous. So it's a neoplasm. And you can tell what the differential or what the differentiation is, like you've already said, sebaceous differentiation. So your differential diagnosis is already very low right there. You've narrowed it down dramatically. And so you think it's benign, right? You said benign.
Yeah.
We already talked about the criteria for benign versus malignant a second ago. So very symmetrical. We can draw a nice, smooth, round line around this thing. So we know we're dealing with a benign adnexal neoplasm with sebaceous differentiation. So now we're in a very small chapter of the textbook.
Yes. So it looks like a komodo-like opening with a bunch of these sebaceous units emanating from the wall.
So there's a central cyst, and then emanating from the wall of that cyst, it's almost kind of like a little pinwheel-like morphology. You've got these sebaceous lobules. Okay. Now there's two types of sebaceous differentiation, right? It's kind of a difficult question in a way, but there's two sebaceous cells that we deal with when we're dealing with sebaceous neoplasms. I'm going to point these out. Here's one, and here's another. What are those two cells I'm pointing to right there? What's this cell?
Like a sebocyte?
That's a mature sebocyte. Yes. And what is this cell?
Is that a basaloid cell?
It's a stem cell. Yes. It's a basaloid basophilic stem cell of the sebaceous gland. This cell matures into this. Now, sometimes we get neoplasms that are comprised mostly of these. And sometimes we get neoplasms comprised mostly of these. So we see this, it's well differentiated. When we see these, it's less well differentiated, obviously. So here we're dealing with a neoplasm that's got extremely well differentiated sebaceous glands that have formed, and they're forming off these little residual mantle zone areas coming out of the center of this little cyst structure. So do you know what the diagnosis might be?
I would favor a folliculosebaceous cystic hamartoma.
Okay. Do you like that name?
It's a hard one to say. I guess another name for it would be a sebaceous trichofolliculoma.
That I like a lot better. I like that much, much, much better. Why do we like that?
It kind of describes exactly what it is. It's a
Yeah, right. This
trichofolliculoma.
looks just like a trichofolliculoma. It's got a central cyst. It's probably got some little, rudimentary vellus hair shafts in there. It's got that radiating pinwheel-like morphology. And instead of having small inferior portions of the follicle, although we still do have a little bit of that over here, perhaps, we've got sebaceous glands. We've got mature sebaceous glands. So I like that better. That's the diagnosis is folliculocystic, folliculosebaceous cystic hamartoma, but it's not really cystic. It's a true cyst. So it's not cystic. It's a misnomer. It's a bad name. It's really better to call it a sebaceous trichofolliculoma, in my opinion. So, but it's a nice example. It's a hamartoma. So we don't really necessarily need to draw a line in the sand between the difference between a hamartoma and a neoplasm. Hamartomas are new growths, so they are neoplastic in a way. They're malformations. So I don't think you need to really delve into that distinction so much. But it is a nice example of well-defined sebaceous differentiation. And see, this is like the mantle zone of the hair follicle. So if we went to like a normal hair follicle, went to that zone beneath the infundibulum, and then the inferior portion of the follicle, the isthmus, that little area can give rise to lots of different things. Give rise to sebaceous glands, give rise to apocrine glands, give rise to little hair follicles and everything. So lots of things can arise in that location. That's a stem cell garden, if you will, that can lead to lots of things. And in this case, it led to this sebaceous trichofolliculoma. Good. Nice example of that. I don't know if they'll show you that on the board either, but you never know. This one they probably will not show you on the board, so we'll just kind of work through it.
Good morning, Dr. Cockerell. This is James. I can take this one.
Okay.
We're examining a punch biopsy here.
Good.
Actually, the section on the right gives some clues to where it came from. We see some follicles and sebaceous glands, but we don't see any solar elastosis. So I would favor this coming from a hair-bearing region like the back.
Good.
Or for a young person, of course. This is a neoplastic process. There's no infiltrate, immune infiltrate. The epidermis is normal. In the dermis, we can see a proliferation of blood vessels. Specifically the blood vessels. Well, at this power, you can see clearly that they're single walled and collapsed. So
You think it's a neoplasm with vascular differentiation.
yes.
Can you tell based on just the architecture whether it's benign versus malignant?
At this power, probably actually. So at this
You,
power,
you can you can at this, or you cannot tell. I'm
based
sorry.
on that question, I suspect you. I think you can. But I'm not certain. And
Well,
the
okay, you said you can, so
yeah.
you have to tell me why you think you can.
Because there's no
But if
collagen
we're using our architectural criteria, because at this power, unless you're Superman, even Dr. Ackerman couldn't tell the cytology at this power. But basically, if we're looking at breadth, symmetry, circumscription, some of those kind of things, can you assess those here?
yes.
You okay? Tell me how you can tell.
So
Do you
this
know how
is
broad this lesion is?
say again?
Do you know how broad this lesion is?
No, I do not.
No, they took a punch and just plunged it into the middle of something, right? So we don't know how broad this thing is. I mean, this could be, 100 centimeters wide. We don't know. How deep does it go? It goes pretty deep. It's not all the way to the bottom of the specimen, maybe, but it certainly goes down to the bottom of the reticular dermis here. So we can't assess breadth, symmetry, and circumscription here, right? So we're not going to be able to rely on those criteria as to whether it's benign or malignant. So if we're dealing with a vascular neoplasm, that's kind of important, isn't it? So what are the two main things you have to worry about when you're dealing with vascular neoplasms?
Angiosarcoma and
Yeah, angiosarcoma or not angiosarcoma, right? So if you're dealing with clinically, let's say you see an 80-year-old man that comes to your clinic and he's got this broad bruise-like area on his scalp, and your differential diagnosis is angiosarcoma, I would implore you not to do this type of technique because we can't assess those various features, which we really need for angiosarcoma. And there's a subtype of angiosarcoma, so called very well differentiated angiosarcoma, that looks super bland and benign histologically. And I've seen the diagnosis missed and delayed and end up in a court case because of that. So beware of taking punch biopsies of things like potential angiosarcomas. People do it. They think it's a good technique because they think it gives you a nice, beautiful little punch. That's a great specimen. But we really do need to assess those criteria to tell whether something's benign or malignant in many cases. So we're sort of hamstrung a little bit here. So we can't use those criteria. We have to use other criteria. But you're right. We're in the category of vascular neoplasia. We got a punch biopsy. So now we're going to have to look at other things to tell us whether we think it's angiosarcoma, malignant vascular, or non-malignant. So now tell us how we're going to do that.
So at a higher power, we can see an absence of atypia and an absence of mitotic figures.
Okay, good. Can you
Furthermore,
see an angiosarcoma with absence of atypia in mitotic figures?
based on what you just said, then yes.
Yeah, you can. You can see it. So you got to be careful just using those criteria. Now, are there any other features here that help you in this specific lesion?
In this lesion, there are. I don't see any collagen, encompassed collagen or dissected collagen bundles.
Okay.
And I don't
Tell
see
me
any.
what you mean by that specifically. That can be an important criteria.
So
Criteria.
for
What do you mean by that?
dissected, I would look for a collagen bundle in which I see a vascular channel running perpendicular to it, cutting it in half or into two
Okay,
parts.
so it's like diffuse interstitial involvement of the dermis with irregular vascular channels rather than being sort of grouped together like we see right in this area, for example. I agree with you. That is a helpful clue. That is seen more commonly with things like patch stage Kaposi sarcoma And you can see that also in angiosarcoma also. So we don't see that here. So that helps you. Is there anything else that helps you here?
I also I don't see any so for incapacitated collagen, like any circle of collagen that's circled off by a tumor. I also do not see any reactive fibroblasts or immune infiltrate.
Okay, so usually neoplasms will tend to have more of an inflammatory infiltrate coming in to try to wipe out the neoplasm. That's a clue. It's not really a great criterion. But just looking at this vessel right here, is there anything that's seen more commonly in a benign vascular lesion than a malignant vascular lesion that I'm pointing out right here?
That it is single-walled.
Well, notice that these endothelial cells are plump and large. And that's not usually seen in an angiosarcoma. They'll usually get these endothelial cells, if they are large, they're very atypical. They may be floating freely inside the lumen of these irregular staghorn, bizarre blood vessels. But we see a well-defined vascular lumen like this that's lined by these large plump endothelial cells protruding into the lumen that don't have any atypia or any mitotic figures. That's helpful for a benign. That's more commonly seen in benign lesions. We don't see that in Kaposi's. We don't see that in angiosarcoma. It's usually seen in benign vascular proliferations like hemangiomas and things of that nature. So that's another helpful clue to this. Now, this is an unusual vascular lesion. You may have had a chance to study this and learn about it if you guys choose who's going to do which lesion. So what's the diagnosis here?
Microvenular hemangioma.
Yeah, it's microvenular hemangioma. I'm glad you looked it up. I'm glad you studied it. What's the main issue with microvenular hemangioma? Why is it an important diagnosis to know about? And you will not get this on the board, by the way.
If you're trying to rule out Kaposi's sarcoma, you could find this.
Well, it can simulate KS. It can also simulate an angiosarcoma also. And some of the features that you just mentioned are correct. You usually see well-defined blood vessels. There are too many per unit area, but each one of them is relatively well-defined when we look at it. And they have these prominent endothelial cells, and you do not see spindle cell morphology. You don't see dissecting, diffuse, poorly defined vascular channels present dissecting throughout the collagen bubbles, but you do see a lot of these blood vessels per unit area over a diffuse broad area. And so that's really the way that we distinguish these from one another. There's one other way that if you feel like you need kind of a crutch, if you're not a very good morphologist and you need something to help distinguish these, what can you do to make yourself feel better if you need to, instead of taking a Xanax?
HHV8 stain.
HHV8 stain, and that'll be negative in this versus positive. But you don't really need an HHV8 stain when you see this morphology. So that's good. It's a good example of this. You're not going to see it on the board. It's a little too esoteric for you. But this you can see on the board.
I'll do this one. So this looks like a shave. And
yes. Why do you think they shaved this? They were just mean to us, or why do you think
maybe they thought it could be like a squamous cell? I don't know.
Yeah, good.
Yeah,
they thought this was cancer.
Yeah.
They really and truly did. In the real world, they thought it was cancer. Do you think it's cancer?
No, but it crossed my mind. I thought, yeah, maybe. I was like,
power. Yeah, you can say, you know,
yeah,
there's always epithelium up
yeah.
here. So what made you kind of get out of the cancer category?
Just, you know, it was just the amount of inflammation, and then just seeing, and then kind of looking in the inflammation. There were.
What kind of inflammation are we looking at?
It's
here?
like nodular.
Okay, it's a nodular. It is a nodular dermatitis. Good. What can you subtype and tell us a little bit more about what kind of inflammation is in these nodular aggregations?
So it looked, it also just looked like a lot of mixed inflammation. There was
mixed inflammation. When we say mixed, what's in the mixture?
So I saw lymphocytes and some plasma cells.
Plasma cells, good.
And then some histiocytes is mostly what I saw.
What about here?
It looks like is that a little granuloma.
Yeah, there's an
big
area,
one.
whenever histiocytes predominate in an area, we call that granulomatous inflammation. And when we see neutrophils plus histiocytes like that, what do we call that?
Neutrophils plus histiocytes.
Neutrophils plus histiocytes. There are some neutrophils in here too.
Yeah. Hmm.
We call that suppurative granulomatous inflammation.
Okay.
Which is more seen very commonly in what kind of settings?
Infection. Well.
Yeah, infectious diseases.
Mhm.
Infectious disease. And the most common is like a ruptured cyst or ruptured folliculitis. But we always want to be concerned about an infection when we see that pattern, especially when it's a diffuse nodular pattern. And we have this change, which is called what?
Pseudoepitheliomatous hyperplasia.
Yes. If you see this, I want you to instantly have a reflex that says this could be infectious disease here.
Yeah.
And Dr. Rosen wants you to think that way also, by the way. So now we're going to higher magnification. Well, we're going to go on a bug hunt. We're going to go see if we see bugs. Did you see any bugs in here?
Yeah, it looks like right in the middle. It's like a little spherule.
Yeah. So if you're going to get on the board examination, this is what you're going to get. You're going to get something like this. You're not going to have to like search forever. They're going to expect you to recognize this pattern. They're going to expect you to look at this, expect you to see this, and then they might give you a multiple choice question. So what are you going to put on the multiple? What do you look for in the multiple choice?
Looking for in the multiple choice. As
What
far
answer are you looking for here? You've looked at say, okay, this is infectious or spherules. So what answer are you looking for down there?
looking for Coccidiomycosis.
Yeah,
or-
Coccidiomycosis. Okay. And you look down there and you see that. And then you also see rhinosporidiosis. Are you going to choose that one?
I
Your
don't know.
choice now.
Yeah, I
You
don't.
know, you're going to miss this question, you're going to get it right.
Right. I'm not sure how different that is. So I'm not sure on the
Okay.
details.
Okay. They like to do that
Mhm.
because they want to make you, they want to test your level of certainty. So they want to say, well, you know, we know that rhinosporidiosis also causes spherules. Does it cause spherules that look like this?
I'm guessing they look different, but
They look a lot different.
Okay.
Ton different. They're way bigger, and they're not actually even fungi. They're actually they're kind of like a parasite. They're almost considered, you know, a little bit more, some people used to think that they were fungi. They've actually done genetic studies and, you know, they're really kind of closer to parasites than they really are to fungi. They're kind of more like the alien, those eggs in Alien, you know, that you see they're kind of larger and they have a lot larger, the little spherules, the little intracellular organisms are much larger than these tiny little spores that are inside these. So they're way bigger. So they don't look anything like this. So you need to go back and look at one of those in the textbook and then look at this and say, I see, they don't really look the same. They're just trying to trick me.
Okay.
So don't get fooled. Now they might put some other stuff in there too, like tuberculosis or Hansen's or atypical mycobacteria. So just make sure you're looking. The best place to find the organisms, if you see an abscess, if you're going to look quickly, look for that. Look inside multinucleated histiocytes, especially if you're looking for blasto and that kind of thing. One other thing that we'll sometimes see very rarely is you'll actually see the barrel-shaped arthrospores in the cornified layer, interestingly enough, of Cocci. That's very rare. You don't see that very frequently, but you can look up there too. And then the spherules often get transepidermally eliminated, so you may see them up in this area also.
Okay.
So this is Cocci. So you're absolutely correct. You don't want to miss this. It's a gimme. So they're going to, when they show you these infections, they're like, you see it, you identify the bug, you get it right. So that's great that you got that right. Okay. This is a beautiful, fantastic case. And they very well could show you this on the exam.
Hi, good morning. I can take this one.
Okay, good.
This is a punch, and then I see a lot of like inflammatory infiltrate right under kind of the basal layer, and then there's some destruction of the basal layer in some areas as well.
So
I
what's
see
the
some,
pattern of the inflammation here?
I would say that's interface.
Yeah, I think it is. There's two
Um,
types of interface, right?
there's lichenoid
There's lichenoid, and then what's
and
the other?
vacuolar.
Good. So of those two, which one does this seem to fit better with?
I was thinking lichenoid.
You're thinking right.
Yeah.
You're thinking absolutely correct. Good.
When I
What kind of
zoomed in,
cells are we looking at here?
I
Is this
see
lichen planus?
lymphocytes and histiocytes.
Okay, they're paler than lymphocytes. So we're going to throw out the diagnosis of lichen planus, right? We're not going to think of lichen planus anymore, are we?
Yeah. You don't think so, LP? Or
We're going to say it's lichenoid, but it's not lymphocytes,
yeah.
right? So we're going to say it's not lichen planus.
Okay.
So that narrows our differential quite a bit, doesn't it?
Yes,
So what kind of cell? You said these things may be histiocytes here.
I think so. I see some EOs as well when I zoomed in.
Those two, good. So we're talking about maybe a lichenoid histiocytic mostly, or some cells that look like histiocytes mostly. That's a short differential, very short. So what do you think about when you think of, if I call you, say, lichenoid granulomatous, what do you think about?
What about like lichenoid drug or like BLK?
Lichenoid drug, if you want to be right, you can always say drug.
Yeah.
So it's possible, but lichenoid drug usually gives you lichenoid with lymphs. It actually looks more like lichen planus. It's not really classic lichenoid granulomatous, but it can, but that's kind of cheating because it's always right. But there are about 3 or 4 other diseases. They're not like 20. It's always
Like
good. Short
lupus, fixed
Say that
drug.
again?
Lupus?
Not
No.
no lupus, not with histiocytes predominate.
What about fixed drug?
No, because that's an
No.
interface. Vacuolar,
What
with sufficient
about
infiltrate with lymphs and eos.
graft versus host?
No, that's
Sarcoid?
also more lymphocytes.
Sarcoid?
I'm sorry.
Sarcoid?
Um, Usually no, because those are epithelioid granulomas. It's a short different. It's a relatively rare pattern. We don't see it very common. May not know. That's okay.
I'm not sure.
Syphilis is one.
Oh, okay,
Do it.
yeah.
There's a rare form of lichenoid granulomatous persistent pigmented purpuric dermatitis, rare. Lichen striatus can rarely give you this pattern. Lichen nitidus usually doesn't give you this diffuse pattern, but it's also focally lichenoid granulomatous. Granulomatous mycosis fungoides can give you this pattern. And that's about it. That's about it. It's relatively short. Now let's look a little higher magnification. And do we think these really are histiocytes here?
Can it
They
be
look like
plasma
a lot of
cells?
cytoplasm, way more than lymphocytes. So what's the differential diagnosis between histiocytes and other cells that look a lot like histiocytes because they have a lot of cytoplasm in their cells and they're the lymphohistiocytic origin?
Plasma cells?
Okay, plasma cells maybe, but these don't have the clock face nucleus. They've got a lot of granular cytoplasm. They don't have that perinuclear immunoglobulin. And if you look at the morphology of the nuclei in some of these.
Mast cells?
Okay, mast cells, good idea. Those are usually have mast cell granules, so they have more cytoplasm than a lymphocyte, but they have the fried egg appearance, curtain cross section, and the hot dog appearance cut in longitudinal section. But notice that some of these have what look almost like kidney bean nuclei, and notice how they're getting sucked into the epidermis. They're epidermotropic. So what other cell likes to live here that's got a lot of cytoplasm?
Oh, Langerhans cells?
Langerhans cells. Good. Good. So what's the diagnosis?
Could it be MF?
It could be, but these are virtually all Langerhans cells. So now
Mhm.
what's
Langerhans cell histiocytosis?
Langerhans cell histiocytosis, one of the Langerhans cell proliferative disorders. Exactly. That's what this is. So that's the other thing that kind of goes in the differential of lichenoid granulomatous. They're not really histiocytes, they're really Langerhans cells. And so obviously you do a CD1A or S1 protein, which is going to highlight these cells. So this is Langerhans cell histiocytosis. And, we don't know for sure what type of Langerhans cell disease. They could have letter Seaweeds disease and be quite sick. They could have self-healing congenital Langerhans cell histiocytosis goes away, Hashimoto-Pritzker. They could have a lot of different patterns, but this is a good example of that. And so notice the cytology of the cells. And the other clue here that's a little different than the lichenoid granulomatous differential is that you've got the epidermotropism. So of that pattern, probably the closest would be granulomatous mycosis fungoides, which could give you this. But Langerhans cell histiocytosis commonly gives you epidermotropism. It's in the differential diagnosis of the pagetoid intraepidermal disorders. So this, melanoma, MF, Merkel cell, sebaceous carcinoma, bone squamous cell carcinoma in situ, patches, those are the things that you have to keep in mind when you see this intraepidermal pagetoid proliferation. Okay, great. All right, let's do one more real quickie. This is super fast. You guys need to get out for clinic, so who wants to do this one rapidly?
Okay, so for this one, we've got a shave, and I'm seeing.
Get a punch. It's a lousy biopsy.
Well, we've unfortunately got a shave here, and I see predominantly inflammatory patterns with like a superficial perivascular inflammation.
Yeah, and it could even be deep. That's why we really wish we had a punch.
Right. And then in terms of epidermal change, I do see some vacuolar interface as well.
Good, good. Nice contrast to the last case, right? More of a lichen. Now we got vacuolar. So what's our differential diagnosis with a vacuolar alteration like this? Lymphocytic infiltrate. What's this stuff here?
In the dermis, we see a little bit of, I think, mucin deposition.
Yeah, I get a lot of mucin. So what's the differential?
So with the mucin in the dermis and the vacuolar interface, you can think of a connective tissue disease like a dermatomyositis or lupus.
Good, good. Now, which one is it?
What an excellent question. I was
why did I ask you the question like that? Why did I ask you in that fashion?
I mean,
because I want you to become a militant dermatologist. You're going to get asked that question one of these days from an internist. And so what's your response going to be?
Hopefully not clinical correlation.
Yeah, that is the answer. You say, I can't tell.
Okay, is that the answer? Okay.
They can look the same. They can look the same under the microscope. So don't ask me to tell you which ones they are. You need to go do a serologic study.
Yeah, help us out.
What's the 8A? Do they have a SCL70? What's going on? So you need to throw it back to them. Don't let them try to force you into committing to something that it's impossible to tell apart. If I were going to bet on this, if we're betting a beer, I probably would favor lupus, because generally lupus gives you a deeper infiltrate and than you see with dermatomyositis. But this actually happened to be dermatomyositis here. So this patient had known that positive muscle enzyme studies was weak and all this and the other. So this person had dermatomyositis, but the histology of the two can look identical. So if a rheumatologist tries to bully you into making a diagnosis of dermatomyositis versus lupus histologically, you need to say, go pound sand. I'm not going to tell you. Make them figure it out, because all we can tell you is that it's connective tissue disease here. We couldn't even tell whether this might be drug-induced lupus. It's got this one little finding here. It looks almost like a follicular plug. What form of dermatomyositis gives you follicular plugging and kind of look like PRP? This is for the last bonus question. I
I'm
didn't
not
tell you,
sure.
teach you something you didn't already know, you'd be a waste of your time this morning.
I'm not sure.
The Wong, W-O-N-G type of dermatomyositis.
Okay.
Wong type. It's not wrong, it's Wong. You know,
Wong.
nobody's got
Okay.
a list. Truly the Wong type of dermatomyositis. So go back and read about that. It's a subtype of DM that gives you follicular plugging. It can kind of look sort of reticulated and point to the dermis, and they can get it look a little bit like PRP clinically. All right, well, good job. Thanks for participating this morning, and we will see you guys next month.